People have really good reasons for being in rural areas. They love rural areas. They care a lot about their communities. And so solutions to healthcare problems in rural communities need to focus on maintaining local access, not helping people get further and further away from their homes.
Today, I'm excited to welcome to the show someone I have had the pleasure to get to know most recently in his work with the Michigan Hospital Association and providing amazing expert analysis of two of my favorite topics, an expert in public health and political science. And how those are intersecting right now is quite interesting. We're going to talk to Dr. Shepard about this. We're going to explore some of the current trends that are happening in politics right now as it relates to healthcare policy. So I'm excited, Dr. Shepard, to have you in the studio, your first time in the studio on our podcast. So for our listeners who may not know you, again, this is listened to across the country. Could you give us a little background of your history, education, where you hail from, and what you're doing now?
No, thank you so much for having me. It's an honor to be here. My name is Michael Shepard. I'm an assistant professor in the School of Public Health in the Health Management and Policy Department at the University of Michigan. I'm a political scientist by training and did my PhD at Vanderbilt University. I grew up in rural Kentucky in a small town outside of Bardstown, Kentucky, which is right in the middle of the state. So lifelong rural person. I've been at the University of Michigan. This is my second year. And prior to coming here, I was an assistant professor at the University of Texas.
Dr. Shepard, did you ever consider that you would engage in such a dialogue as you have recently when you first started in your undergraduate, because it was probably a little different then?
Oh, certainly not. So initially I wanted to be a high school teacher in a rural area in Kentucky. And I got my feet wet doing that in the community in which I went to undergraduate. I discovered that as much as I love teaching, you couldn't pay me enough to be in a room with a bunch of 14-year-old boys.
It's brutal.
At that point, I decided to have a career change. After a few years of doing various political related things, I went to grad school at Vanderbilt. And even then, I think it certainly wasn't the plan to be focusing on rural health with my research or rural politics. But over time, it became clear to me that that's what I was most interested in. And I've had the great fortune, at least career-wise, of that becoming something more, I think, of use for the policy world, for politics, and for the U.S. in general.
Yeah, it's become very meaningful for folks like me who serve on the board of Michigan Hospital Association, as well as running rural hospitals. Empowering us with data and information is so critically important, and you've been able to do that. So we're going to dive into those in just a moment. But for this episode, we'll talk about the current outlook of healthcare in Michigan and beyond. With funding cuts and policy change, hospitals are bracing for some of the most severe challenges we've ever faced in our history. And what I want to do today is try to help address those concerns. And how does that level on the playing field when we start using data? How do we maximize that information to be able to have conversations with our elected officials and with our boards and others in the community? And so we'll talk about social health equity, the Rural Health Transformation Fund, and of course, what all this has to do with rural health. So why don't you give us an introduction just of the recent work that you've done most recently with the statewide healthcare advocacy, just in general. You've done a lot. And I guess from your perspective, what's been going well with that? And then we're going to dive into some other areas.
So I would say back in the spring, I started to be alarmed by the proposals coming from Congress related to changes in Medicaid. Medicaid is a critically important program, especially for rural communities. About half of rural births are paid for by Medicaid. Rural hospitals are deeply reliant on Medicaid funds, and hearing that such stark cuts were on the horizon potentially was alarming to me. So at that point, I started to gather as much data as I could to get a feel for, what the current state of the world is for rural health in terms of its Medicaid reliance. I started writing op-eds in places where I could get, hopefully get some of this information out there to alert people to the serious consequences on the horizon from enacting such stark Medicaid cuts. That process included taking meetings with lawmakers in Washington, taking meetings with folks in the state of Michigan to really sort of make my case for what these cuts could really mean if they were to come to fruition. After they did, I think my focus became more on, okay, how do we make the most of the situation? How do we sustain and perhaps even build access in an environment where funding cuts are making that harder to do? And the Rural Health Transformation Program sort of, I think, at least in the short term, was one venue with which that may have been pursued. And so started speaking with folks around the state, Michigan Health and Hospital Association, as well as lawmakers in Lansing about maybe what we should be prioritizing, what could be done. And again, as I think as an academic, the op-ed is often our route for doing so, but also just trying to make sure that the state had access to as much data as possible to address rural health needs. I think that process was illuminating for me in a lot of ways about some of the various problems facing different parts of the state of Michigan, but also I think in some cases illuminating for I think that actually the lack of knowledge that a lot of policymakers hold about healthcare provision in rural communities in general. Rural areas have particular needs. They have particular challenges. And I think oftentimes the discussion of health policy and health access neglects the perspectives of rural providers and rural people especially. And, I'm determined to do something about that with my academic career. And at least in the short term, I viewed advocacy around rural health issues at this moment as an important part of that.
Yeah, absolutely. And so, I would submit to you that I believe it was one of the darkest hours in my lifetime, the vote to dismantle how hospitals like mine get paid for serving the disproportionate number of patients that we have on Medicaid. And as you said, 70% of my payer mix for Medicaid payer mix is found in obstetrics. Okay, 72% of my entire payer mix is the federal government for my entire hospital. So we rely heavily on government payers because disproportionately, as you look in rural communities, poorer and access to healthcare is oftentimes limited. And so to take an initial cut that they were proposing, honestly, Dr. Shepard, I said, not going to happen. I was truly on the other side going, they're not ever going to pass that. There's no way they could. This, number one, primarily is the base of President Trump. Number two, there is no way they can do this because hospitals will be dismantled. We had Scott Becker from Becker's Healthcare on the podcast not too long ago. That commissioned a task force with his team. And, 700 hospitals were slated to close if this passed. And that number still rings true today. So looking at that from your lens, were you as, I'm going to say, optimistic as I was early on leading into this? Like, they're not going to actually do this. And I guess at what point in that revelation were you like, okay, we have to change course? And I want you to answer the question for me, if you would. How do we change that course? Because I think that's a bigger question. I
was definitely somewhat surprised, at least that the law took the particular farm that it did. I think we as political scientists like to think that, industries that are sort of either reliant on or dependent on government resources are strong counterweights toward unfavorable change. We think oftentimes that the status quo bias of our system is in some cases maintained by the hospital industry, by the insurance industry, by the pharmaceutical industry. And so most of the time when we're talking about that, we're thinking about things that might further socialize medicine, if you will, and not further, not lead to reductions. But in this case, I think that it was surprising to me how quiet a lot of different healthcare sector
Agree.
actors were
Agree.
in the lead up. And I think that reveals in some ways exactly what you're talking about, which is disbelief that people would engage in such financially harmful policy making. What it showed me was that we have, I think, if not entered into an era where we've been in one for a while, in which the policy realities of any given policy are in some ways divorced from the politics of the situation. Yeah. And I think that leads us to moments like this where a policy can be passed largely to provide a political win for the president and the president's party that is divorced from what people need, what people want. I saw no survey that revealed that Americans were in favor of cutting Medicaid.
Yeah, in fact, just the opposite.
And I saw no evidence that the healthcare sector viewed these things as anything other than, potentially an existential threat to their financial model. And, I think part of this is indicative of people having false stereotypes about social programs like Medicaid in terms of who benefits. The work requirements that were enacted are a perfect example of this. Work requirements sound like a good thing to people.
Why not, right? Can we rally behind it?
Yeah.
Right.
In reality, almost everyone that can be working
is working. Yes.
And it's not as if there's, a group of people out there that we can really say in large number are not. And so something that sounds good is actually a policy that leads to lots of people losing their access to health insurance who are meeting the criteria. It's an administratively burdensome policy that pretty much by definition can't save money unless people lose their health insurance. And so, I was in disbelief that it would happen. And then it became clear to me, I would say within 3-4 weeks of final passage, that this is where we were headed. And I think actually the creation of the Rural Health Transformation Program in the negotiations, to me, was the final confirmation that this would happen. It taught me that the advocacy work and lobbying that healthcare providers and others had been doing to say, you're going to kill rural hospitals, had worked, and members of Congress had recognized that they were creating a massive financial problem. And they wanted to be able to rhetorically point to something to say, that's not true. And that was when I really became convinced, I think, that this is going to pass and this is going to be a massive problem because there's virtually no way that they're going to put enough money into such a program that it could make up the difference. But that showed me that line of attack had really worked and convinced them that they were vulnerable from doing this for this particular reason. But ultimately, the solution that they had for the problem that they were creating wasn't up to muster. And so my focus at that point shifted to, well, we're going to get a certain amount of money potentially.
Yeah. And we're going to dive into that in just a minute. Because interestingly, who doesn't want to stand tall to fraud, waste, and abuse, right? And this concept or this idea that, a 26-year-old's in his parents' basement gaming, and ironically, their storyline and their smoke and mirrors actually paid off for them, and at the cost of the community worker, the pastor that I know, the mom who has 3 children that works at the Family Dollar. These are all true stories. These are stories that we tell. But it sounds great. Those fraud, waste, and abuse. No one wants to stand beside that or behind it. And it worked. So you found yourself on the Hill. You're lobbying of sort, right? I mean, you're trying to advocate. You're having conversations with legislators. How did that go for you? Because I'm going to tell you, to be truthful, mine were empty. I did not find, and this is my party, okay? And I did not find one sympathetic ear in my party who understood. It was believing a falsehood that in Hillsdale, Michigan, okay, that we had excessive amounts of fraud, waste, and abuse. It's so egregious. I'm so angry because I live this every day. There's no fraud. There's no waste. There's no abuse. There's no 26-year-old sitting in his parents' basement. We're talking about real people, real faces. And so I listened and I grew very frustrated with the reality. And then they strip $1 trillion, right, from us. And they give us back this little thing, this $50 billion divided by two, $25 billion divided by all the states. Who knows what the applications, even, we're going to get into that, is even going to look like. We know what it looks like, but who knows what's going to get approved. But how was that experience? I mean, and is that shaping some of your opinion now of how you're tackling in the use of data?
Yeah, it was, I would say it was easier to get a meeting to talk about the realities of rural healthcare finances with Democratic lawmakers. I was told many times by various Republican lawmakers that they weren't particularly interested in hearing from me, which is, they're busy. They have tight schedules, and a random academic from Michigan is probably not a high priority, which is fair. But I think my perception was either an unwillingness or a lack of desire to hear data that could make the situation come to life for them, or simply just a lack of energy to engage on this. And I've found similar things in the state where I think there's a hopeful optimism by some that there are things that'll change and this won't happen, or that there's some other political actor out there that's going to come down and fix all of this. And I think in some ways it's a cognitive dissonance process of just not really wanting to believe that such drastic changes are coming down the pike, and that such negative things are things that we have to deal with. I found, a mixture of people who really don't know a lot about what's going on and were interested in finding out, and some who don't know and really weren't.
Interested, right.
And so I think it's, I teach about advocacy, I teach policy, and American healthcare policy is particularly complex for anybody to really get a handle on. And I think we expect a lot from our lawmakers in terms of being policy experts when they're really not.
Right.
And this was an area in which I think I learned that the level of detailed knowledge of what's actually going on is pretty low, even for people who consider themselves healthcare policy people. And so the process was disappointing. But as I often tell my students, like, the big chunk of doing advocacy work is being willing to have no one answer your email or be told no, have the op-ed fall completely flat, whatever that looks like for you. But if you believe in something, you should do what you can do in your own professional capacities or as individual citizens to try to make a difference. And, I really believe that rural healthcare access is an important problem, and doing things to make that worse is never going to sit right with me. And so I think I had hoped that I would meet other people or find other people on the inside that felt that way. Instead, I found a lot of really great people on the outside that feel that way, but ultimately who were left out of a lot of the important decision-making processes.
Yeah, and that's part of the research that you did, right? So let's talk about research and the importance of it, because you've come to several presentations, various venues that I've been part of, and I've never hear your opinion. What I get from you is solid, concrete data points, information, connecting the dots. And that's critically important. And it's often overlooked in today's political world because we want to go off emotion, name calling, and those things. But let's strip it back to what it should be. And let's talk about research. You've done a lot of it. Where is the research taking you today in a platform that you would just like to say, you know what, this is what I've studied. This is what we've looked at. This is what we need to do. Yeah, no,
it's I think as an academic, I really do focus on what the data tell us. I have opinions about things, but in terms of what I study, what I'm engaged with at a professional level, my opinions really don't matter. I want to pursue what the truth is. And I think the truth is a really important thing to to maintain, to focus on, and to bolster with evidence. Right now, where my head is largely twofold. One is thinking through how the various state applications for the Rural Health Transformation Fund are enacted and how those things connect to downstream population health outcomes into the future. And then related to this is what healthcare access is going to look like in rural communities into the medium-term future. A lot of my work in the past has focused on things like how Medicaid dollars are critical for keeping rural hospitals open and how things like Medicaid expansion stabilize the finances of rural hospitals in many places, and how that experience or in many cases, the lack of that experience where people did experience closures, how that shaped their understanding of health access, health policy, their own health, politics in general. So my head now it's much more forward thinking and trying to be in position to understand how rural communities in general are responding to these cuts. And that includes understanding better how rural health providers are navigating these changes, how state governments are engaging in responsive or in some cases non-responsive policymaking to the federal changes, and then looking into the future, how the mass public, how rural people have their health, their politics, their social lives influenced by what I perceive to be likely pretty starkly increasing rates of rural hospital closures into the future.
Yeah.
You know, you mentioned earlier that hundreds of rural hospitals are at risk of closure, and I like to remind people that was before this bill was passed. And so what we might expect is something worse in the long term.
Far worse.
And I think, you know, one of the things that people, I think, forget about or maybe just don't know about rural places is that, you know, people have really good reasons for being in rural areas. They love rural areas. They care a lot about their communities. And so solutions to healthcare problems in rural communities need to focus on maintaining local access, not helping people get further and further away from their homes.
Absolutely.
And I think I'm alarmed by the tendency to view rural health as something that should be further consolidated in large cities, or what really needs to be solved are difficulties getting to large cities from rural areas, or maybe rural people need to just move instead of focusing on providing high quality healthcare where people live. And so looking into the future, I'm collecting data on where we observe hospital closures into the future, the correlates of those closures with community-wide outcomes, economic outcomes, as well as health outcomes. And then ultimately, how does this make people feel about politics and government? A lot of rural people feel like society and government in general have let them down, and they have good reasons for thinking that, and in some places especially. But this is an instance where I think that's directly happened, and the line between bad outcomes in rural areas and government is actually really clear. And so I'm curious to see, what kind of variation we have on that moving into the future, how it maps on to how people feel about politics in the future, and then more importantly, what all of this means for rural health over the next few years.
Yeah, it's our question of the day. What does all this have to do with rural? Dr. Shepard, you've done a phenomenal job today at outlining the importance of engagement. And we're going to drop your information in the show notes so that way if someone wants to reach out to you, that's okay, right?
Please do.
And they're encouraged to reach out to you. You've done some great work. So thanks for joining us on Rural Health Today. We appreciate it.
Thank you for having me.
And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on current state and rural health every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com. And make sure you subscribe to the show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire. Our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.